Hello CyberMDs and welcome to another lecture. Today we'll be discussing coronary heart disease as it applies to the USMLE STEP 2 exam. The topics in this lecture are going to include coronary artery disease, stable angina, unstable angina, in-STEMI, and STEMI. Please remember to subscribe and leave us some feedback so that we can continue to provide free medical education resources to students all around the world. Alright, on this slide, I've laid out the underlying pathology just as a quick reminder for you from Step 1 studying. Please feel free to pause here and review this if you think that you might need it. On this slide, we can see the progression of disease associated with worsening diagnoses above the diagram. At its core, as this spectrum of disease progresses, it results in a mismatch between oxygen supply to the myocardium and oxygen demand by the myocardium. So either the plaque or thrombosis causes a lack of supply, or there is an increase in demand from the myocardium as the patient becomes stressed, maybe with exercise, and there is a subsequent mismatch. And that end result of that mismatch is going to be the patient complaining of chest pain, which is often referred to as angina. So there are certain characteristics of this disease spectrum in the patient's history that we can ask about that are considered typical, while others may be considered atypical. They're listed here on the screen, but the most important thing to remember is that the typical symptoms are the quote-unquote classic symptoms, and there are three major populations that you should be aware of that often present and are having potentially a myocardial infarction, STEMI or in-STEMI, and those patients present, again, often with atypical symptoms. These are going to be females and diabetics and elderly population. So keep in mind that those three populations may have more atypical symptoms in there as a part of their presentation, and so you shouldn't rule out coronary heart disease or some sort of acute coronary syndrome, which we'll discuss later. You shouldn't rule that out just because the symptoms aren't typical. Okay, when it comes to risk factors, you can ask about modifiable risk factors such as the diabetes, hypertension, hyperlipidemia, smoking, and obesity, and then you will see in their chart hopefully any family history. You can ask them about family history, and then you will have this patient's age most of the time as well. So for a review of symptoms, you can make sure you can ask about shortness of breath, or have they ever felt like they were about to pass out? Have they had any nausea or vomiting associated with this chest pain that they're most likely complaining of, as well as any sweating. These are all things that will maybe make you a little bit more suspicious that there is some kind of myocardial infarction or some kind of tissue damage going on. It may make you more concerned the more positive things they have in that review of symptoms. For the physical exam, you can make sure that the chest pain isn't reproducible or positional. You can listen for any new murmurs, rubs, gallops, any breath sounds. You want to make sure there's breath sounds bilaterally, but you also want to make sure that there's no crackles or rails or anything, as pneumonias can sometimes present with chest pain as well. And then you can also palpate the anterior chest wall to rule out crepitus, so you're ruling out any kind of subcutaneous emphysema that might be due to something like a Boerhaave syndrome, where you have that transmural tear of the esophagus, allowing air into the mediastinum. Now that we've discussed the background of the disease process, let's discuss the various stages and how they can be differentiated as well as treated. First, we'll start off with coronary artery disease. On this end of the spectrum, the atherosclerotic plaque exists, but the patient is going to be asymptomatic. Therefore, they have no pain with exertion and they have no pain at rest. There's no clinically significant ischemia going on in these patients, so their troponins will be negative as there's no damage to the myocardium. Additionally, because there's no ischemia or no mismatch between oxygen supply and demand, there are no EKG changes. In order to diagnose patients at this part of the disease spectrum, a physician may order cardiac stress testing with an EKG. This stress test may be an exercise stress test if it's safe for the patient to participate in that test, and it may be pharmacologic stress test in other situations where it's not safe or the patient's incapable of doing so. Additionally, CT angiography may be used if the stress testing is completely contraindicated, but you must remember that getting that CT is going to expose your patients to large amounts of radiation. Lastly, an echo, which is a transthoracic ultrasound of the heart, may be used to assess left ventricular function, but this is not diagnostic and is typically an ancillary test in these patients. Patients with asymptomatic coronary artery disease typically have less than 50% obstruction of their vasculature, and the main objective of treatment in these patients is to prevent anginal episodes from occurring. So the first line treatment for these patients are beta blockers to reduce the contractility of the heart and subsequently the myocardial oxygen demand. Alternatively, if patients can't tolerate beta blockers for some reason, maybe you can use calcium channel blockers instead. Rarely the two are used together. However, hypotension and bradycardia may become a concern, so it's not often done. The next line of drugs that may be used are long-acting nitrates, which helps dilate the coronary vasculature and increase blood flow to the myocardium. The last line of treatment is a drug known as ranolazine. It's relatively new. This drug is a sodium channel inhibitor that subsequently reduces intracellular calcium in cardiomyocytes. Thereby, it's going to reduce that contractility and the oxygen requirements of the myocardium itself. Other therapies for these patients are going to be things that include anything addressing and controlling the patient's modifiable risk factors. So you're obviously going to want to treat their diabetes, their hypertension, their dyslipidemia, their obesity. If they have any of those risk factors, make sure you are treating those things as well. So the next diagnosis in the progression of this disease is stable angina. The difference, really, which is bolded on the slide, is that the patient begins to have pain with exertion because their occlusion has now grown to be typically greater than 70%. And with this level of obstruction, the patient actually increases their myocardial oxygen demand. A mismatch is then created distal to the site of that obstruction. And that's going to create that exertional angina that the patient's experiencing. However, the pain in these patients often will go away with rest and can typically be improved with a nitrate. So the troponins, again, are negative. The EKG is going to be negative. There won't be any STEMI because there's no damage to the myocardium yet. The obstruction hasn't progressed far enough for there to be tissue ischemia, just this mismatch with exertion. So these patients' diagnostic process is essentially the same. However, treatment in these patients can also include short-acting nitrates to help the patients when they experience those anginal episodes. The next progression after stable angina is unstable angina, which is the first diagnosis that is traditionally recognized as being a part of acute coronary syndrome. In this diagnosis, the occlusion has continued to grow and is now typically 90% or more. Because of this increase in obstruction of blood flow to the myocardium, patients will now experience anginal episodes at rest. With that being said, these patients still do not have any permanent damage to the myocardium, and therefore their troponins will be negative and you won't see any STEMI on their EKG. Because these patients are most often presenting to the emergency department, their initial diagnostic testing should include an EKG and troponin because you want to rule out other ACS diagnoses such as an NSTEMI and STEMI that require a rather quick trip to the cath lab. However, in the setting of a negative troponin and a non-concerning EKG, what do? You should calculate a heart score. If the patient is high risk, they should likely be admitted for observation and further workup, while a low to moderate risk patient may be able to be discharged with outpatient follow-up soon after they leave the hospital. Whether the patient is admitted or discharged, however, they should receive stress testing or CT angiography to make the diagnosis and see how severe that obstruction actually is. With regards to treatments for patients with acute coronary syndrome, they often receive some form or combination of the famous monobash mnemonic when they are first seen for their anginal episodes in the emergency department. Let's run through each part of this mnemonic and discuss the treatments. It's worth noting that not all of these will be used in unstable angina or even in every patient, as the patient's not completely blocked in unstable angina, and there may be other factors at play which could prohibit a patient from receiving one of these medications. So the M stands for morphine. Morphine may be given for patients to help relieve their chest pain, but this is typically reserved for patients who have excessive chest pain, as there's data that suggests it worsens outcomes by interfering with antiplatelet medications that are also going to be administered to help this patient out. The O stands for oxygen, and so we continue to revisit the idea that the oxygen supply and demand mismatch at the level of the myocardium needs to be addressed. Supplemental oxygen can help to saturate the red blood cells with oxygen, maximizing the oxygen supplied to the myocardium even in the ischemic areas. The N stands for nitroglycerin, or in the mismatch areas, The N stands for nitroglycerin. Again, nitro is going to vasodilate and help to supply more blood and therefore more oxygen to the myocardium, addressing that mismatch. Just remember that these drugs are contraindicated if the patient has a right ventricular infarction on the EKG due to the reduction in preload that they may cause. They are also contraindicated in patients who have had some sort of phosphodiesterase inhibitor within the past 24 hours, typically as treatment for erectile dysfunction, as the combination of the two can cause a very severe, a very profound hypotension. The first A stands for antiplatelet. These patients typically receive aspirin for antiplatelet activity whenever they come into the door of the emergency department, and they may be put on it long term by a primary care provider. However, these patients often receive what is referred to as DAPT, D-A-P-T. So they often receive DAPT, which stands for dual antiplatelet activity, or dual antiplatelet activity treatment. So they will often take the aspirin along with some sort of P2Y12 receptor inhibitor, such as ticagrelor or clopidogrel. The B is going to stand for beta blockers, which, again, as we mentioned earlier, will lower that myocardial contractility and therefore the oxygen demand in patients who are unless the patient has too much hypotension or they're too bradycardic, and then they won't be able to take these drugs. But again, we're using beta blockers here in the long term for these patients to reduce that mismatch and restore normal cardiac function or normal homeostasis to the heart itself and to the myocardium itself. The second A is going to stand for ACE inhibitors, which can help to prevent the cardiac remodeling that we often see in these patients. They will reduce mortality and increase the left ventricular EF up to a year out from the initial infarction if this patient were to have an infarction. The S stands for statins, and so these patients should receive high-intensity statin therapy, usually atorvastatin 80 milligrams daily, or rosuvastatin 20 to 40 milligrams daily. Those are typical dosing. And again, that goes back to addressing the other factors that could be at play for these patients, other risk factors. This statin is going to help to address some of those. And then finally, the H stands for heparin. If you occlude a vessel, there will be hemostasis, which we know is a part of Virchow's triad. And that can lend to the activation of the coagulation cascade. So think about if this patient did have complete occlusion and they were much further along in this disease progression and they had a complete occlusion, and then everything distal to that is going to be hemostatic, and you can activate that coagulation cascade, and then you will get other emboli traveling other places. So these patients can receive heparin for a few days after their myocardial infarction if they have a myocardial infarction, and that will help to ensure that they don't have clots floating around elsewhere in their body. Okay, now that we have a basis for understanding the pharmacologic treatments that may be used in acute coronary syndromes, typically these monobash will be used a little bit later in the disease progression. But let's move on and talk about the next progression of this disease process, which is an NSTEMI. In an NSTEMI, the change is that during the workup of the patient, you will see an elevation in the patient's troponins, and there may be some EKG changes. The important thing to remember, however, is that the EKG changes are not ST segment elevations. The EKG changes that are typically associated with NSTEMI are going to be ST segment depressions. The EKG and troponins are enough to make the diagnosis in these patients. These patients will also receive some combination of Mona-Bash. However, they need urgent treatment with revascularization to restore blood flow to that infarcted area. Therefore, they may receive PCI, which stands for percutaneous coronary intervention, and that's the fancy medical term for a stent. Alternatively, a patient could receive something called CABG, CABG is the acronym, and that stands for coronary artery bypass grafting, which is exactly what it sounds like. They will take vasculature and use it to bypass the occluded portion of the coronary arteries. So the question then becomes, when do you do PCI for a patient, and when do you do CABG? The answer to that is that it depends. However, for the purposes of the exam, remember that CABGs are a very large vegetable. So if you have a very large occlusion in a very large coronary artery, so think a proximal LAD occlusion, go for CABG on the exam. In addition to this, CABGs have many leaves. So if there are 3 or more occlusions, pick CABG. However, if there are smaller or maybe more distal occlusions that number 1 or 2, then go for percutaneous coronary intervention or PCI or stent on your exam. Now, lastly, let's talk about the big bad wolf, STEMI, ST segment elevation myocardial infarction. In STEMI, you have 100% occlusion of a coronary artery that leads to elevated troponins and those ST segment elevations on EKG tracings. Making the diagnosis is much of the same as in STEMI, and the treatment is going to be the same with regards to CABG and PCI. However, you'll notice I added TPA to this list. It's important to know that the widely accepted standard for what we call door to balloon time is going to be 90 minutes. And door to balloon time simply refers to how quickly the patient gets into the cath lab and gets the balloon up in the cath from the first moment that they come in to contact with a medical professional. So 90 minutes, door to balloon time. Again, door to balloon time is 90 minutes. However, if you find yourself in a facility where there is no way that this patient can get to a cath lab, you're in a very rural setting, and there's no PCI nearby, there's no CABG available nearby, not at your facility, not at anything remotely close to you, and then you know that 90 minutes isn't going to happen for them for a cath lab. You can use fibrinolytics, such as TPA, so that you can safely transfer that patient, and hopefully that TPA, the idea is that it helps to revascularize while they're in transport to a PCI or CABG capable facility. Okay, let's recap real quick on this slide. Our patients with coronary artery disease are asymptomatic, while patients with stable angina begin to have chest pain with exertion, and then their pathology worsens, and then they have chest pain at rest, and that's unstable angina, and now we've entered acute coronary syndrome territory. The main difference between unstable angina and NSTEMI is that the troponins begin to rise, and then we take it one step forward to a complete occlusion, and where the troponins are elevated and there are ST segment elevations on the EKG itself. Finally, let's talk a little bit about the differential diagnosis for patients who come in with chest pain. I like to use the mnemonic displayed here on the screen, PETMAC, and for each thing except for the letter E, there's going to be, for each letter except for the letter E, there's going to be 2 diagnoses associated with that you can remember. The ones on the top row are going to be the more dangerous things, and the ones on the bottom row are going to be less dangerous things. The things on the top row, you want to rule that out in patients who have chest pain. You want to make sure there's no pulmonary embolism, they don't have Boerhaave syndrome, they don't have a hemothorax or a pneumothorax, they don't have tamponade, they don't have an aortic dissection, and they don't have any kind of acute coronary syndrome process. You can then move on and rule out these other things that are slightly less dangerous. Pneumonia, for GERD, I actually use T. It's a bit of a cheat in the mnemonic, so I use throw up to remember GERD. And then all of my carditis, I throw under myocarditis, and that helps me remember pericarditis and endocarditis. And then for A, it's also a bit of a cheat for the second one. That's going to be attacks to help me remember panic attacks and anxiety attacks. And then as far as C goes, remember costochondritis can also be a cause of chest pain, and so can other MSK things. Patients could just be sore from a workout where they weren't expecting to be sore, or maybe they had a car accident in there, or they had some sort of anterior chest wall trauma where they have MSK pain. Maybe they have rib fractures from a trauma, and that's the etiology of their chest pain. So these are all things to consider. And then also consider vasospastic angina if the historical information fits that clinical picture, and as long as that patient has other things that make you less suspicious for any of these acute coronary syndrome processes or any of these other causes of chest pain. And then lastly, I just wanted to mention a zebra diagnosis that isn't often talked about. It's called spontaneous coronary artery dissection, and that's exactly what it sounds like, and it can be a cause of chest pain, and you can see troponins rising, and they will eventually have STEMI findings on the EKG as that vessel gets occluded due to the dissection. But if you have elevated troponins and they keep rising and they keep rising, you should be suspicious that this is possibly a diagnosis that can be made in these patients. Just something to keep in your back pocket. All right. Additionally, if you have any other questions about this lecture, please drop them in the comments below for us. We'd love to get some feedback and let us know what kind of lectures you want us to do moving forward. That's all. Again, thanks for tuning in. Please remember to drop some feedback so that we can continue to provide some free medical education resources for students all around the world. We'll see you in the next lecture.